Hi, my name is Bernard Thebaud. I'm a neonatologist and professor of pediatrics at the Children's Hospital of Eastern Ontario. I'm also a clinician scientist at the Ottawa Hospital Research Institute and the CHIO Research Institute. Today I will be talking about the therapeutic potential of mesenchymal stromal cells to repair the preterm lung. The objectives are to summarize the current understanding on the therapeutic potential of these mesenchymal stromal cells for chronic lung disease of prematurity. I have nothing to disclose. Bronchopulmonary dysplasia will unfortunately celebrate its 50th anniversary in 2017. And the reason for the apparent lack of progress in treating this disease is illustrated on this cartoon, which shows the histological developmental stages of lung development. And when BPD was described for the first time by Dr. Northway in 1967, babies were born around 34 weeks gestation. Improvements in perinatal care have allowed the survival of more and more immature babies so that infants at risk of developing BPD today are born around 24 weeks gestation. And you can see that these babies are born at the late canalicular stage of lung development, which is just at the stage when the airways and the blood vessels get juxtaposed. So before that stage, no gas exchange is actually feasible with our current resuscitation management strategies, which means that we are very close to the biological limit of viability. In addition, the preterm lung is exposed before, during, and after birth to adverse events such as growth restriction, chorioamnionitis, oxygen exposure, postnatal steroids, which further impedes the growth of the immature lung, and which leads to the arrest in alveolar development, the current histological hallmark of the new BPD. So clearly, much more needs to be learned about normal lung developmental processes, how these mechanisms are perturbed during injury, such as bronchopulmonary dysplasia or BPD, in order to design new therapeutic strategies. New insights over the past 10 years in stem cell biology have suggested the therapeutic potential of these cells for various diseases, including experimental BPD. These mesenchymal stromal cells that have these very promising repair potential are niche cells to hematopoietic stem cells. These mesenchymal stromal cells can be easily isolated from the bone marrow, but also from the cord blood or the cord. They are plastic adherent. They can differentiate into cartilage, bone, or fat, and are therefore multipotent. But in addition, they also express certain cell surface markers that allows to identify them as mesenchymal stromal cells. And this is the definition or the minimal criteria that have been set out by the International Society for Cell Therapy. And while the definition of these mesenchymal stromal cells is still evolving, their therapeutic potential has been demonstrated in numerous preclinical studies. This study here on the left shows the effect of mesenchymal stromal cells from the bone marrow given intratracheally to neonatal rodents exposed to hyperoxia. And you can see in the middle the hyperoxia lung characterized by dramatic arrest in alveolar development, and below a drastic decrease in lung vascular growth as well. With the administration of intratracheal MSCs, we can see prevention of the arrest in alveolar development and partial prevention of the arrest in lung vascular growth. Similarly, on the right, a study in neonatal mice exposed to hyperoxia showed that the intravenous administration of mesenchymal stromal cells from the bone marrow attenuated lung inflammation, and this is one of the main mechanisms of action of these mesenchymal stromal cells. Of course, as a neonatologist, we are very interested in the umbilical cord or umbilical cord blood as a potential source of these mesenchymal stromal cells. These data here show the efficacy of airway delivery of human umbilical cord blood-derived MSCs or human umbilical cord-derived pericytes or PCs, which are precursors of MSCs. These cells were given after established alveolar injury, and you can see the capability of MSCs to restore almost normal lung architecture in this experimental model. These very promising results have led to a first-in-human clinical trial. It was a phase 1 dose escalation trial performed with umbilical cord blood-derived MSCs given intratracheally in a dose escalation fashion to 9 preterm infants at a relative early stage of evolving BPD, around 10 days postnatal life. And this study showed that it was feasible to administer these cord blood-derived MSCs through the trachea and safe. And this study warrants a phase 2 study that has been currently accomplished. So in summary, perinatal tissues are a rich source of stem progenitor cells with potentially high repair capabilities. Here I showed the results obtained with mesenchymal stromal cells, but there are also other stem cells or repair cells that warrant further exploration. In preclinical studies, these mesenchymal stromal cells show safety and efficacy over the short and the long term. These mesenchymal stromal cells do not act via a cell replacement, but via a paracrine effect by releasing a number of bioactive molecules that protect resident cells, allowing then for repair of the damaged organ. Early phase clinical trials are underway, and it would be very important to optimize the manufacturing process because this will impact cell quality and, as a consequence, the results of clinical trials. With this, I would like to thank you very much for your attention.